Cohort 1 or the IDEA program. What an exciting moment. And delighted to be here with you again to present the second cohort and their projects. So you can see all the players. I very intentionally put this slide up, and you can see the distribution in terms of countries from the northern part of Asia Pacific right down to Oceania. And, really comprehensive group of wonderful folks who over the year have been exposed to improving themselves on a very personal level and multiple different models of leadership skills and skill building. And my colleague Shannon Moore, who's hiding there, really it was a delight to work together. And thank you all for this opportunity. You're the ones that started this. And it's so fun to see that several people from Cohort 1 are now even on the council. And how will you get the folks from Cohort 2 engaged in the region? So without further ado, and I should also thank our coaches, Roselle Guzman from the Philippines, Monica Malik from Calcutta in India, and Martin Stockler. So where are those folks? We're hands up over here so everybody can see them, and thank you so much. Absolutely. We could not have done this without this partnership and this leadership team. So thanks to all of you. I'm going to change the slide, and I'm going to invite our first team to come forward and make their presentation. So would our first group please come and join us?
Okay, sure. Right. Hi, good afternoon, everyone. My name is Dr. Kevin Chua. I'm a radiation oncologist from Singapore.
I'm Dr. Piada, medical oncologist from Thailand.
Hi, good afternoon, everyone. So I'm Jason Ko from Manila, Philippines.
Hi, I'm Melita Zahid. I'm a medical oncologist and cancer genetics specialist in Australia. And together we are Team RISE. And our project was to look at how to meet high patient demands in low resource setting. So this may be a familiar sight across clinics in Asia. This happens to be a photo of an oncology clinic in Thailand. As you can see, there are a lot of patients waiting to be seen. So imagine among these patients is one of your loved ones who is nearly completed or who has nearly completed their chemoradiotherapy, definitive chemoradiotherapy for head and neck cancer. They are experiencing mucositis, nausea, and other toxicities. So Piada, as a medical oncologist in Thailand, how long would you have to see a patient like that to address their concerns?
To answer Milita's question, I like to share our high demand we face in our hospital. We have only 10 oncologists here, and we see around 2,000 cases every month, and that's 100 patients per day. So we have just only 10 minutes for address everything, all questions and medical needs of cancer patients. So let's think about that. Only 10 minutes to address everything, and it's the challenge that we face, and it's the problem we need to address.
Jason, as a radiation oncologist in the Philippines, what is it like for you?
So just like in Thailand, we also have a limited time, about 10 minutes. So for this time, 10 minutes, we need to address the clinical needs of the patients and as well as address the social and financial aspects of treatment for them to access care. So it's quite complicated.
And Kevin, what is it like in Singapore?
So in Singapore, the problem is similar, but it takes on a different form. So because of significant manpower shortages in many outpatient clinics, physicians actually run these clinics unassisted. And so if you couple that with the administrative procedures and the fact that patients do have higher expectations, we really do have very limited time, less than 10 minutes to address all their issues.
So it has been documented that in Asia, primary care physicians spend on average, less than 10 minutes per patient clinician consultation. And we extrapolate that it would be similar in the oncology setting, which means that patients and their families wait for hours to be seen for only a few minutes. So we wondered, how can we use the time that we do have more efficiently? Patient-reported outcome measures, or tools that assess patient-reported outcome measures, has been documented to improve the quality of patient-clinician consultations in the West. These are just some examples of randomized control studies that have demonstrated overall survival benefit, as well as improved and maintained quality of life, less demand on health services or health service utilization, and also prolonging time spent that a patient is able to remain on treatment. So we wondered, what about in Asia? Could a tool like this be feasible and acceptable in an Asian context to make our consultations more efficient? When looking at our project, we wanted to select something that would be high impact and low effort. That is, low resource demand and lower barriers to implementation that can fit in within existing systems and infrastructure. So we felt that looking at improving our ability to elicit patient-reported outcomes may be one of those easy wins that we can hope for. So currently, patients and their families wait in the waiting area for a while. And in the 10 minutes that they're seeing the doctor has to discover what the main concerns are today, what the issues are, and then spend the remaining time managing or addressing those concerns. But what if, while they're waiting, we administered one of these tools so that the patient and their caregiver could highlight the major concerns that they have today, so that when the doctor is seeing them in the clinic, they can focus on those areas of concern, reducing the amount of time needed to do the assessment and spending more time on management and making overall everything more efficient.
So for our group, we identified a tool. So the tool that we identified is the Edmonton Symptom Assessment Scale. So this is a validated tool used in the clinic to assess symptom burden in cancer patients. As you can see here in the slide, it is a numerical scale and aim to address the common symptoms as listed in this slide. It aims to quickly capture the patient-reported symptoms in clinical visit prior to even seeing the clinician. So it aims to improve symptom management through better communication. So as you can see here, this is a real-life example of an ESAS form filled in Singapore. As you can see here, for this patient undergoing weekly or daily radiation therapy, as you can see here, the patient has minimum to no symptoms at all. But as you can see here at the last part, there is a provision for you to indicate other symptoms that are not listed. So for this patient, the patient have problem with urination. So knowing that beforehand, give the opportunity for the physician to be able to address that. And should the physician is not able to address on his own, he can make the appropriate referral for patients to be managed well. Okay, for Team RISE, coming up with this solution involve a comprehensive approach. So our team initially did a literature review to define what is the clinical practice in the region. After that, we met with local and international experts to refine our approach. As we go along, we iteratively learned and adapted, and integrating these new findings to create a solution to address the high demand patient burden in a resource-limited setting. To be able to demonstrate that the use of ESAS is possible in our local setting, we conducted a multi-center pragmatic design pilot study on the use of ESAS across different sites in Asia. So we implemented translated versions of ESAS across 4 sites in Singapore, Thailand, the Philippines, and India. We aim to recruit 200 patients per site and administer these questionnaires. With the aim of looking into the feasibility and practicality of using ESAS in this culturally diverse setting. For this, our population includes patients seen at outpatient cancer clinics, as well as we chose paper-based as the mode of delivery, as this is accessible or accessible across all sites.
So our primary outcome measure is compliance, because essentially we are trying to look at the issue of feasibility in all these outpatient clinics across different cultures, different languages, and different healthcare settings. So what is compliant? A patient is compliant if out of the 10 questions on the ESAS tool, he completes at least 5 questions. And our hypothesis was that essentially in all these sites, we will be able to achieve a compliance rate of at least 85%. We have secondary outcome measures as well, and so for these, we administered surveys to qualitatively assess some of the feedback from the different stakeholders. So for physicians, we focused on whether or not the ESAS tool improved efficiency and improved discussions with the patients. And for patients, we focused on whether or not the tool improved the quality of consults, whether they felt that it was easy to use, and whether they felt that the tool and the different skills was easy to understand. And so to give everyone an update on the progress of this study, we have now completed accrual in 2 sites in Thailand and Singapore, and it is still undergoing IRB approval in Philippines and India, and should be open shortly. And so to share the primary outcome measure from the 2 sites that have completed the study. So in Thailand, we saw extremely high rates of compliance with 100% of patients completing the ESAS tool, and in Singapore, the compliance rate was 99%.
And next, I would like to share how we learned from this pilot study from Thailand. You can see here the overall feedback is positive, and we get the clinicians' feedback. They feel that this ESAS form improve efficiency, improve their discussion, and improve quality of care. And our patient also find that this ESAS form is easy to answer and understand, and they think that it's relevant to their symptom, and it helps them improving discussion with their clinician. That's from our pilot study experience. We find that this ESAS allow doctor can focus on the symptom that patient most concerned and help them catch up missing symptom effectively. So we can increase efficiency during clinic visit by utilizing the time in the waiting area. And however, some clinicians note that patients rate their symptoms differently than expected. So to address this issue, I think the key to successful implementation is that we need to prepare our team with clear instruction how to use the ESAS properly for our patients and their caregivers, and ensure prior training to our physician to use the ESAS to help them triage the important symptom.
So if you come to our poster on Friday, you will see that essentially the experience that we saw in Singapore was quite similar to that in Thailand. But what I thought I would share is some of the feedback and some of the comments that came from the different stakeholders in Singapore. And so for patients, they thought that it actually facilitated a very empathetic exchange with their physician. Even the caregivers found that essentially completing the ESAS tool with the patients made them aware of symptoms that they were otherwise not aware that the patient had. And when we came to the physician, essentially, I think some of the physicians were surprised at the symptoms that the patients were experiencing. It was for treatments that they expected to have little or no side effects. Some of these symptoms that were reported actually took them by surprise and were unexpected. They generally felt that it did not take up more time and actually made the process of assessing the symptoms more efficient. But there was one physician who felt that the tool actually added more pressure, more time pressure to an already busy clinic. But when pressed further, he admitted that the patient himself found it useful, but also shared that he thought it could be better utilized, the tool, if, for instance, the physicians were better trained to manage some of these symptoms, or if beforehand both the physicians and the patients were briefed, such that if there were many symptoms, then they focused on the key ones. And so this speaks to the implementation takeaways from Thailand as well. So to summarize, these are our key findings. One, patients found it beneficial for their experience. They found it very useful. And importantly, we also found extremely high rates of patient compliance. And at the same time, physicians did not feel that it took up more time, and actually thought it would lead to a more efficient use of that precious time. So in conclusion, we hope that we've been able to convince you that these symptom reporting tools are very important and very beneficial for patients. We, through the process of this LDP, brought us together, and we had this opportunity to conduct this study, which we are very proud of. And we'd like to thank everyone for chipping in. And essentially, how can the Asia Pacific Regional Council help? I think we really need to rely on your influence and your leadership to spread the word for more widespread adoption for these patient symptom reporting tools, because we think they will truly benefit our patients. And really, at the end of the day, what we hope for is, for us to be able to better communicate with our patients in those precious 10 minutes that will improve their lives. Thank you. And acknowledgements. I'd like to thank Monica, our mentor, as well as the leaders in LDP, Frank, Shannon, Vanessa, as well as our colleagues who participated in the study with us, and the patients who contributed so generously. Thank you. And please welcome to our poster on Friday.
So I wonder what questions you all have for our colleagues about their project. Yes, please. Julie.
Thank you. So congratulations on that nice work. I'm anxious to see the next two sites that you're opening in it too, but it's a terrific project. As you were presenting it, I thought, are there other team members that could also be part of managing the symptoms? And I saw you thanked your clinic nurses. So my question is, as part of this, in addition to getting the symptoms ahead of time during the wait, are there other staff who also could be reviewing some of this and supplying information on how to treat the nausea or the fatigue or something as maybe a next step in the assessment of this?
Good question. Actually, that's the way that we conducted the study is very pragmatic, because the sites have different setup on how they manage patients. For example, in the Philippines, it's not customarily that we have nurses to screen the patient before being seen by a physician. So that's why our focus is between the patient and physician. So I'm not sure about Singapore, Thailand. Is there like a healthcare worker that can screen the patient and address this need prior to seeing the physician?
In Thailand, our patient will go to the check-in process first. So to develop this pilot study, I train our nurse to know how to use the ESAs and explain them to our patient during check-in process. And after that, patient will wait for their doctor in the waiting area, so they have time to complete this questionnaire during that time. And for Singapore.
So because this is an outpatient setting, it will be quite difficult to pre-screen some of these patients. In Singapore, how we have performed the study is essentially, it depends on the clinic. Some clinics have, essentially, in every clinic, there is someone who takes the vital signs, the height and the weight, and so we had a whole stack of these ESAS tools that were then distributed according to the patient's spoken language. Whereas in other clinics, then we have the benefit of coordinators who can essentially help to administer these surveys. Yeah.
So I think in terms of after the tool's been administered, there is, as you mentioned, there is scope for that, certain symptoms, I think a trained nurse or a trained healthcare worker could address some of these issues, and that would minimize the burden on the doctors and actually probably give them more time to look at the clinics. but that's obviously a much more, there's funding issue, there's infrastructure issue, and that's something for individual sites, I suppose. David.
So excellent presentation, and not restricted only to less resourced, but there's something we can learn in more resourced countries. I want to reinforce the idea of a symptom or toxicity clinic, not necessarily staffed by physicians, is exactly the next step. But my questions were twofold. The first is about a red flag system. So the Australian prompt care, before they come in, it's already red flagged what are the things to focus on rather than looking at every. So did you think about that? And my second question is, if you had more time, what would be your ideal outcome measures beyond satisfaction?
So I might start, but then they will chip in. So I think that the red flag system would be something to look at. And I guess, you know, when someone scores something really highly to trigger sort of additional processes, I guess, you know, within the limitation of the feasibility that sort of was outside of our scope, if we had more time, then really this is a pilot to hopefully go towards a larger study. So that's sort of, I guess, what was the aim. So I guess when we initially thought of it, we sort of wanted to do the bigger study, but really before we can do that, we need to try it out to see whether it was going to be acceptable.
The outcome measures you would choose
would be sort of the similar kind of things as those systematic reviews, you know, looking at the survival, which obviously requires a much longer term. So if, you know, if we could wish for anything, those are the, I guess, the things that we would look for, quality of life measures, and also the, you know, emergency department presentation, hospitalization rates, because those are the things that I guess are really substantial and meaningful and saves dollars ultimately.
Yeah.
Congratulations, really a terrific presentation. This maybe follows up a little bit with what David was saying. So part of the advantage of using the Edmonton scale that we use at MD Anderson, particularly in the palliative care setting, is to use this scale progressively and, you know, in the same individual, right, to see how an issue of pain can improve, and then having each patient be their own control. So I'm wondering if you had the opportunity, or if in the next iteration of this work you could consider having more than one observation in the same patient. I'm imagining that in many of the settings that we're talking about, as it happens in the country where I'm from, in Mexico, you are not the doctor that sees the patient every time, right? You might see a patient one time and your colleague or a fellow, so there's not a lot of continuity. So I'm wondering if this scale could be used as a way of communication across providers and to measure improvement on that symptom of patient. So do you do that? Do you have observations in the patients? And if not, is that something that maybe could be a next step? But congratulations.
So that's one of the limitation of our studies. The ESAs that we use, it's only a snapshot of an event that the patient is having. So it's a good idea for the next iteration of the study to have a trend, to see if the patient is improving from, for example, a baseline of pain of 8 and 6 at the next provider. Yes, I agree that this can also be used as communication between physicians and between healthcare providers. It can be presented in a graph so that the next physician will be able to address the needs of these patients.
Can I add to that? So in my experience of using paper-based form in an Australian clinic, so, you know, if we sort of, in this setting, it's patient episode, so it doesn't have to be every individual, that's not 200 individual patients. It could have been multiple episode of care for that patient. So in my experience in the paper form, there was a place to store those reports. And so if someone scored 8 in pain, then you looked at what happened the time before, the consultation before. It is a little bit clunky, I think, to do it like that. And ideally, I think in an electronic sort of setup, it's much more easier to capture. But I think that's also a resourcing issue and sort of higher infrastructure demand for that.
So when we were designing the study, I think one of the things we were thinking about was whether or not the patient-physician interactions should be unique, or whether we can do repeated measures for the same patient. And I think that speaks to the same point that you brought up as well, because some of these toxicities can evolve over time.
Sorry. Yeah, sorry, I was just curious, and maybe this would be, my question probably relies more on an electronic system, but you're identifying high-need patients, but we all know there are also very low-need patients who do not need to sit in that waiting room for 4 hours to say they're fine. So could we use this as some sort of triage tool? Yeah.
So yes, I think you're absolutely right, and I think eventually as this tool evolves, I think this is one of the potential use cases. So I think it's definitely one of those things that as we were thinking about which patients to include as well, we were also very mindful about including the patients who were not on active treatment, and so. Potentially at some point, if there was a triage and they looked at it and these patients had no symptoms, then perhaps they could be dealt differently.
And I think there are studies elsewhere looking at the electronic things that are being done remotely, and so the patient doesn't need to be seen. If they're tracking okay, you can continue with the capecitabine or whatever it is that you're on. So, yes.
Whereas in this instance, with the tool, when you see that this patient is relatively well, there's no symptoms, then the entire 10 minutes could be essentially focused on just looking through scans, discussing results, discussing next steps, and so, again, more efficient use of time as well.
First of all, I would like to congratulate your Group 1 because of your very informative and comprehensive presentation. And I would like to make sure that what I heard is that you use the translated questionnaire in our own language. Yes. So I would like to know about what do you use for validation of your translated words, because of different health literacy and education standards in our patients. So I have an experience about our IPOS translation. So very simple pain. So they said they have no pain because in Myanmar, there are different words using that pain. So they said this is aching, this is a spasmodic-like effect. So they use different language. So what is your idea for validation of your words?
So it will be a challenge for some area wherein terms are used differently. Even if it is pain, some will use another word to describe a different thing. What's good in ESAS is that it is widely used in the West already. So that's why there are a lot of validation. There are a lot of validated translation already that are being validated from the previous study. So we are fortunate that these are available and we don't need to do it again, and we use those tools in our specific settings. So.
And to add, actually one of the questions we had in our surveys for patients was whether or not it was easy to understand, whether the skill was easy to apply. And so I think these, again, we were trying to pick up whether or not, even with the translated, validated versions, whether some patients still struggled. Yeah.
Any other questions or comments? Please.
Okay, what a fabulous presentation. I just can help to ask, because 2 countries were able to complete the studies, right? But for India and the Philippines, I'm just curious, what are the problems? What happened in those 2 sites, why we did not complete or there was a delay in the process?
So one of the advantage actually in other centers is that this was taken by their IRB as a quality improvement program in which the IRB was waived, and in some centers, for example, in my center, it is still undergoing institutional review. So that's why we face some hurdles in implementing it. But all of us had agreed that we will be continuing this even after LDP.
Yeah, so watch this space. There's a publication coming at some point.
So is this just purely a comment? Congratulations. This was very informative. I think there's always a lesson to be learned, and I keep thinking about the one physician that felt very pressured and was considering maybe there should be a cancer-specific. So you can think about the future of how could you involve the physicians, because perhaps there are certain symptoms that a particular disease might, entertain itself that may not be captured by that. So that's just a piece of advice, to give. Can you maybe explain, or can you tell us a little bit more about why that physician felt pressure? Because I'm wondering if they're the only one, and if it was a particular disease, or what made him feel that way or her feel that way.
So I think specifically in that one instance, the tool was actually applied in a trial clinic, and so there were lots of other procedures that essentially, so there was a lot of time pressure already to do many things. And I think in that particular instance as well, it was a combination of essentially the patients having multiple issues. And so then he said, if on hindsight, if both the patients and physicians were briefed, that essentially if you have multiple issues, let's just focus on the most important one, the one that's affecting you the most. And then at the same time, even the physicians themselves didn't feel entirely comfortable, for instance, dealing with issues like insomnia, right? And so when you add all this up, essentially I think what that did was essentially add all this time pressure on the physician. So yes, I agree with you. Yeah.
And also our group hypothesized that with the multiple use of ESAS, regular using it in clinics, it will be easier for the physician and for a patient, for example, that had answered it before. So it will be easier for them to answer it. So as we implement it and we are getting used to it, it will be easier for the stakeholders to use it.
Sorry, just a very direct question on that. Did you train the physicians in some way? How did you socialize this with the physicians in the clinic?
So, so every site is very different, so I'll just comment on Singapore first. So in Singapore, essentially we had, along with the ESAS tool, which also came with the qualitative survey, there was an introduction page that essentially explained what this tool was about and what it was meant to elicit. And basically, patients will either read it, or essentially the person who was giving out the forms will also brief patients. Yeah.
Oh, and their doctors, did they get any training?
So with doctors, yes. So we went to the clinic beforehand and said, look, this is what's going to happen. But what also transpired was that essentially there were clinics where essentially they were covering physicians or junior doctors. And then, essentially it was a situation where it's a busy clinic and I'm given this form and I do know what it's used for, but, it's just too much to handle and time pressure and everything. So, yes.
And for Thailand, we train our nurse first to explain how to do the ESAS. And after that, the patient will give this ESAS form to their doctor. And their doctor will recheck everything again to make sure that they rate their symptom exactly or not and manage as clinical practice. Did you train the doctors? We train the doctor before using this ESAS. Yeah.
Yeah, I just would like to congratulations for your project. That's very reflect to the situation reality for the Asian countries. And yeah, I may use this concept being back to my hospital. That's a very great idea. And just one question is that this is right now we have many questionnaire for quality of life in cancer patients. For example, like ERTC C30. For example, why do you interested using ESAS rather than any other questionnaires?
So actually, choosing this ESAS involved like a long process for us. So we consider a lot of things to decide. First, what tool is easy to administer. Some of these symptom assessment scale take a long time to answer. So that's something that we don't want to put a lot of burden to the patient. And second, we were looking for a tool that is widely translated. So we don't have to translate it ourselves. So I think those are the two most important reasons why we chose ESAS. But of course, using other tools is also might be of help as well.
Yeah, no, congratulations, super exciting, and congratulations on your poster and all that you've accomplished. Just a very specific question. Great that you had the other open-ended part of the survey. Just wondering if you saw some commonality, some common things come up in that open-ended section that makes you consider whether an additional item needs to be added to the standard form.
So I think if you look at the ESAS-2, I think the symptoms that are covered sort of cuts across most, all the different scenarios, different cancer types, and patients in different parts of their journey. I find that essentially, you know, when I look through all the different forms, when it comes to the open-ended question, a lot of it was treatment-specific, and or essentially patients who sort of didn't quite understand what feeling of well-being meant, and so then sort of substantiated in that portion as well. Yeah, but I think deliberately, I think that open-ended question was also meant to sort of uncover some of these, some of these symptoms.
Well, we've spent our time. Would you please join me to thank these wonderful